Hi, everyone. Again, I'd like to include my thanks in being invited to this symposium. I think it's a wonderful opportunity to see how midwives can enter into this community, and hopefully we can move forward that way. I, of course, am a registered nurse, London, Ontario. I work in a tertiary care center, which is high risk, and we do 6,000 deliveries a year, and sometimes I really believe my feet feel like I have been to all 6,000 of them, but it certainly is a pleasure to attend high-risk deliveries as well as low-risk. I am a rather unique individual. I work full-time as a registered nurse in the birthing unit, but I also work with the midwife groups in the community. We do have 4 midwifery groups, and I work with 3 of them. So I am somebody who would work as a second attendant, either at home or in the hospital. In the hospital, sort of our model of care for working with midwives, the midwives are completely autonomous and would only require nursing as needed. So it's based on each group, what they believe, what they feel their competencies are. So there are some groups that will run their own oxytocin induction and augmentation, and there are some groups that will not. So in those cases, they would require a nurse to go into that room, and we would be taking over the fetal health surveillance and the oxytocin administration, but not the supportive care. So in that way, the midwife still stays with her client, and in a lot of cases will complete the delivery. It depends on that shared care model that the obstetrician who is on call prefers. It's really interesting to work as both a registered nurse and a midwifery second. And I think that it provides me the opportunity to act as a bridge for the two, the obstetrics and also the midwifery care. There is not always a whole lot of buy-in from communities, from the obstetric team, but the more we work together, the more we trust each other's skills, the more we trust the way care is provided. I'd like to just give you an example of one of the births that I attended recently. The midwife called me for a home birth. She had a prime-MIP, first-time mom, who was fully dilated and had been pushing, so she required somebody for a second attendant. As a second attendant, I am capable of, I have my NRP certification, CPR, so I can do maternity care, maternal care, as well as fetal surveillance during labor pushing, and also neonatal resuscitative care if necessary. And that is exactly what a second attendant is there for, an extra set of hands, support in case it's needed. So when I arrived to the home, the woman had been pushing, and the midwife informed me, okay, we've now heard a couple of fetal heart decelerations. I've recommended to the client that we go into hospital for transfer, and she has declined at this time, which is well within her rights. And so we continued on offering as much supportive care as possible, continued listening to the baby, and we continued to hear deeper, more prolonged decelerations. And the midwife said, okay, I strongly recommend at this point, we need to do a transfer of care to hospital just for a safe delivery. And the client accepted, yes, absolutely. And as the midwife was making the call to the EMS team to come and assist with the transfer, I was able to perform the directives. So I was able to perform the intrauterine resuscitation that was required at the time. I started an IV, I got O2 on her, I got oxygen on her, I did the position changes, all the things that you would do in an intrauterine resuscitation while the midwife was making those calls. When EMS arrived, as a nurse working in the unit, I was able to make that phone call into my unit and say, I've got a prime-MIP coming in, we've had decelerations, this is the history, this is the story, and my charge nurse organized to have the room ready, so we had the birthing unit totally set up. My safety equipment was completely checked. The room was ready to go before we even got there. On arrival, we had a huge birthday party. It was wonderful. We had lots of nurses there. We had our obstetrician's resident was there because the obstetrician was busy and quickly was able to come when needed. We applied continuous monitoring, and lo and behold, the baby had turned position in the ambulance and had a beautiful tracing, and we had a wonderful unmedicated normal vaginal birth that was attended by everybody just because we all wanted to see this little pooper come out and scream and cry, which he did. So it was a wonderful delivery, and in those extraordinary circumstances, I really feel like as a nurse, I was able to facilitate that delivery, facilitate that transfer. It was very stressful at the time, but we had this wonderful outcome, and I think I'm rewarded feeling like I really helped that lady, helped that midwife, and helped my team, my obstetricians, my nurses, and everybody. I was that perfect bridge in between to help facilitate that. If there is a transfer of care, it does go to the obstetric team and the nursing working at the unit at that time. There is the shared care model where, depending on the situation, if the consultant has made an assessment and feels things are progressing nicely, but they just have that level of supervision where they're involved but not taking over care, then nursing can be involved, but it depends on the situation. So
when do you know as a nurse who you report to or take directions from?
If there's a transfer of care, I take directions from an obstetrician.
In that gray zone.
And that shared care? It depends on how I came into the situation. So if I was starting with the midwife, working as a second attendant, then I would take direction from her, from the midwife at that point. If I was a staff nurse working on the floor that day and there was that transfer of care, that shared care, then I would be taking direction from the obstetrician at that time. It depends on what umbrella I'm falling under that day. What hat am I wearing? Am I the second attendant today or am I the registered nurse today?